Free audio post-production by alphonic.com.
Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, it's great to be back for another episode of All Things Cardio-Oncology. And as usual, I want to welcome my co-hosts, Dr. Arjun Ghosh, consultant cardiologist at UCLH and Bart's Heart Center in London, UK. Welcome, Arjun.
Hi, Steve. Hi to the audience. Great to be here with everyone for another ICOS podcast.
Yeah, good to have you. And Dan Lenahan. Dr. Lenahan is the founding executive of ICOS. He is a cardio-oncologist at Cape Girardeau in Missouri. Dan, welcome.
Thanks as always. It's great to be here with all my friends and enjoy the conversation that we're going to hear from Dr. Khalaf. And we hope that people really understand how complex these situations are.
Yeah, complexity seems to be the name of the game whenever we do these. It is a pleasure to welcome today Dr. Shaden Khalaf, who is assistant professor at MD Anderson Cancer Center in Houston, Texas. She specializes in cardiac imaging and in particular its application to cardio-oncology. And so we're going to talk with her about pericardial disease in particular. But before we get there, Dr. Khalaf, I wonder if you could just tell us a little bit about your background, your experience in imaging in particular, but how you developed your interest in cardio-oncology.
So thank you all for hosting me. I'm really honored to be with you all. This is a field that I stumbled upon actually as an imaging fellow in the MRI lab. I had a great affinity for cardiac masses. It seemed like when I was reading the studies, the cardiac masses populated to me. And over time, I just enjoyed them. And I became the dedicated fellow to read those studies. And over time, I was just impressed with the therapies and how good they are and, seeing regression of masses. And that kind of set me to this path. So I specialize in multimodality imaging. I cover all cardiac imaging modality, and I'm currently the sole imager for MD Anderson. I practice cardio-oncology, both clinical, we do some research, and my expertise is in the field of imaging. And along the way with masses, pericardial disease has landed to be my next favorite thing. And so this is something I'm really excited to talk to you guys all about today.
Great. That's very nice to hear how you got into cardio-oncology. And I think for a lot of people, it's getting in a non-traditional route, but then it drags you in once you're exposed to cardio-oncology, I suppose. So great to have you with us. So this episode is on your second favorite bit of cardio-oncology imaging, I guess, the pericardial disease. So maybe you could just explain to the audience about the different types of pericardial disease we see in cancer patients.
Yeah. So when we talk about the pericardium, we talk about the sac surrounding the heart, right? It ranges. When we talk about pericardial diseases, we talk about effusions to begin with. We talk about inflammation, which is pericarditis. And over time, we talk about more complex emergencies of the pericardium, such as tamponade and such. All of these are in a spectrum. You can start with a pericardial effusion and could be, and it's a very complicated topic, right? It's one of those conundrums. Is it the chicken or the egg? Is it the cancer? Is it the cancer therapies? Is it just the progression of the disease state? Is it how cachectic and pro-inflammatory the patients are, the type of treatment they get? So it's always a spectrum. Not two cancer patients are the same. We all know in the field. Is it the disease process itself? Is it the combination of therapies, the radiation? So when we think about it, we start thinking about, hey, is there pericardial effusions? And those are very common within cancer patients, and they vary from a trace effusion to very large effusions presenting with tamponade, and we can talk about that. But we also deal with inflammation within the pericardial sac, and we know cancer patients are a high incidence of pericarditis. Looking at, say, the Danish study that spanned 2 decades almost, and patients who without a diagnosis of pericarditis, those who had pericarditis and then were followed over time had almost a 50% increased incidence of malignancy over time. And the highest risk was within a diagnosis of cancer within the first 3 months. So that's another thing that we consider here in the realm of pericardial disease in cancer patients. And then emergencies, just like STEMIs in the general population being one of the presenting cardiac emergencies that people train in. Cardiac tamponade are the most common cardiac emergencies in cancer patients. So this is the spectrum that we often talk about. And then my favorite topic, usually pericardial or masses, we get pericardial involvement, tumors within the pericardium. Those tend to be metastases. We get primary cardiac tumors, which are rare, but they can span within the muscle into the pericardial sac, creating pathology within the sac. And that also varies from a simple effusion to a bloody effusion, and over time inflammation to an effusive constrictive physiology, which is what I hate most and to deal with, because these are the very, very complicated situations that we are often faced with, and usually there's no good solution when it gets to that case. So I guess this was, you asked a simple question and I gave you a very long-winded answer.
That's okay. I think that's reflective of usually the patient scenarios that we have to evaluate these things. But so what type of cancers do you see are most commonly associated with some sort of pericardial involvement?
So as I just said earlier, primary, cardiac malignancies or tumors are very rare, thankfully. Cardiac metastases are on the spectrum of lung, breast, melanomas are the ones that we see more often. And those are the ones, especially lung, are the ones that we see most commonly to develop pericardial pathologies with, along with leukemias and lymphomas. Those also have a very high incidence of pericardial disease with them, effusions, and oftentimes pericarditis as well. So all cancers can, but those are the most common. So lung, blood disorders, breast, melanomas, and a lot of the others. But I would say those are the top 4, 5.
So it's interesting. We just had our international training program where every couple of months we have a presentation from one of our training sites. They presented a case that was diffuse B-cell lymphoma that was really quite aggressive, and they did a superb job. But it's interesting, the presentation on the echo and subsequently the MRI is that you saw this big right atrial mass that kind of went into the septum, and then of course there was a pericardial effusion. It wasn't the most prominent, but it was certainly present. And then there was a lot of mediastinal disease. So, this is sort of like mixing all those things together of what you have been talking about. But, diffuse B-cell lymphoma would be a presentation for these problems. And, that's not commonly the, most typical cancer that might have pericardial involvement, but certainly it's on the range, and you kind of have to just keep your eyes open regardless of what the cancer is, if it's anywhere in the chest, then it could have significant pericardial involvement. I don't know. How do you deal with, those types of things where you see a mass or you don't have a biopsy and you're trying to piece together, you know, what the ultimate problem is. And then once you do that, then you might have a better solution. So how do you go through that whole thought process?
Yeah, no, these are excellent points that you bring about. So we often know that when we are dealing with pericardial disease, it usually correlates with more advanced cancers. But oftentimes, it can be one of the presenting um, causes, or the kind of like the hidden diagnosis of cancer is in a pericardial effusion. The pericarditis might be the first thing that these patients come in with. So it is a complicated topic. So we employ all our imaging modalities. Echo first for diagnosis, simple, fast, rapid test. Oftentimes, when these patients present, they're not feeling well, so they need a rapid imaging exam to evaluate. Echo is the fastest. We're able to do it at bedside. No radiation to the chest. We're able to get within minutes our diagnosis. We work alongside with our interventional colleagues. If it's within the heart, we do echo guided biopsies in the lab. I oftentimes scrub in with my interventional colleagues to help them get a tissue diagnosis. If the mass is extracardiac and not accessible easily, we work with IR colleagues to get a tissue diagnosis. So tissue is the issue. We need to get to the type of cancer so that we can start treatment. Oftentimes these effusions resolve with cancer therapy. So they're the result of something that is causing the body to get inflamed. If it's not an emergency, we need to start initiate an emergencies. It's not like florid tamponade. We work with the oncologist to initiate therapies. I hope that answers the question.
Yeah, I mean, it's kind of an open-ended question because each patient is going to have their different paths, and obviously echo's the easiest, but frequently you need more than one set of images and to look at different
Exactly.
aspects.
And
So,
so,
yeah, one thing I would wonder, there's always been, so classically in the world of cardiology itself, when somebody came in and they had some pericarditis type symptoms and maybe a small effusion, they would say, "Oh, give them non-steroidals." But I never liked that approach. And then there's been some recent data about colchicine, and then even now there's a newer drug. I've never actually used it, and I would be curious if you have. I forgot the name of it, but it's for recurrent pericarditis. Do you have any
so these are the
thoughts
I
about
think you're
all those
referring.
things?
I think you might be referring to the different classes of the IL-1 inhibitors or antagonists, um, such as rilonacept or anakinra. Yeah. So when we talk about pericarditis in cancer patients, it's a complicated topic, right? In the general population, the presentation of pericarditis should be treated with several weeks of anti-inflammatories, high dose NSAIDs, along with at least 3 months of colchicine for the first flare of pericarditis. Steroids in that instance are contraindicated at the first presentation because it increases the incidence of recurrence of pericarditis. For second presentations of pericarditis in the general population, steroids can be added. And then for recurrent, um, repeat recurrence of pericarditis, which tend to be a very debilitating and chronic disorder, now we have approval for new agents. And there are three agents within the class of IL-1 receptor antagonists that work in different ways to inhibit the IL pathway of inflammation and reduces the inflammasomes. And we use them, okay? we have a couple of cases, I'd say maybe a handful, maybe a dozen of cases amongst our group that we've initiated them, because they're initially, when we talk about, starting to use biologics in cancer patients, there's oftentimes this discussion with the oncologist: how is it going to affect the other therapies that the patients are already on, right? And oftentimes now immunotherapy and dual immunotherapy is the first line treatment options for a lot of cancers. And you're giving stuff to tamper the inflammatory pathway, along with a pro drug that is activating your inflammatory pathway. So, and none of the trials really included cancer patients, like the remainder of our cardiac trials. So there are a handful of case reports that are coming out, and now ongoing studies that are including these IL-1 antagonists for treatment of pericarditis in our patients. And honestly, from our limited experience thus far, so far so good. The patients I've had did very well, but that took a lot of discussions, very close follow up of these patients when we initiate them on these therapies, and it's a multidisciplinary team. Obviously, the quarterback is the oncologist. We're kind of the offensive team. We're trying to get the patient to the finish line, and we oftentimes seek the assistance of our rheumatology colleagues, which use these drugs more often than not to get their experience. So we work as a team when we pull the trigger on getting these patients on these newer agents. But this is not the usual path. The usual path in cancer patients who develop pericarditis is we try to start them on anti-inflammatory therapies, including NSAIDs and colchicine. However, oftentimes thrombocytopenia is more often than not an issue, and colchicine increases bleeding risk. These patients also have concomitant, very significant GI issues, a lot of gut sloughing. So the oncologists and the patients are often not wanting to take these agents because of drug-drug interactions or the adverse side profile. You're giving somebody with severe diarrhea more colchicine is not a good option. So more often than not, these patients get started on high-dose steroids, and we try to do a slow taper over several weeks to calm the flare. This is the most common treatment course. And then if we deal with recurrence, then we do a longer course of steroids. Usually, I think after a second course of a flare, is when I start considering the IL-1 inhibitors for my patients.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
So Arjun, have you ever used any of those?
Yeah, so we have used anakinra on a couple of occasions and received reasonably good results. I think the problem is often in these kind of chronic effusions, and you're worried whether this becomes effusive constrictive, and long-term use of anti-inflammatory agents, steroids, and where do we go from here? So I guess one of my questions now would be about the patient who maybe has been treated, has this chronic effusion, one of the questions we often get asked is how often should we be monitoring with imaging, and the patient's treatment has finished. So I guess this is a common question. So I don't know if Dr. Khalaf has any kind of comments in terms of the chronic effusion after treatment, how best to manage those patients.
Yeah, this is an excellent question, Arjun. So as I started the conversation, echo first, echo always. However, in complex pericarditis, CMR plays a very important role in our patient population. So whenever we deal with effusions or pericarditis that's not behaving in the way we expect, so the patient's not responding to the anti-inflammatories at the doses we're giving, we use cardiac MRI. Cardiac MRI is an excellent exam. It gives us very good tissue characteristics. It allows us to visualize what's going on within the heart and the pericardial sac. We also are able to look and assess for active inflammation within the sac itself. And that helps me more often than not in patients that have chronic pericarditis to guide my therapies. So I get a CMR. I assess the extent of inflammation. I start therapies. I might have to escalate steroids for a period of time, give more pulse dose steroids, try to add a little bit of colchicine. Oftentimes, we end up with 0.3 grams of colchicine once daily. And oftentimes, that does the trick, believe it or not, in some situations. Even a very low dose of it, some patients respond very nicely. And then I give it usually at least 6 weeks on CMR to re-image and assess the pericardium. Those are chronic situations. We're not going to see something overnight dramatic, but as the patients tend to improve, we see less inflammation within the pericardial sac. Now, those patients that are not responding, or patients that come to us, so we practice in a tertiary referral center, and we have patients from all over the world, obviously coming here for high level cancer care. And we as consultants deal with a lot of issues with patients who've been treated elsewhere. And, in the Western world, we still, tuberculosis is not a thing. I don't, I don't see that on oftentimes. But when we get patients from the East, we often, we have to consider other disorders that come in. So tuberculosis remains to be a leading problem of pericardial disease and chronic constrictive and inflammatory issues within the pericardium. So we have to broaden our thinking cap and exclude other disorders that we don't normally see. Along with,
just let me develop that thought a little bit more. And you actually mentioned this earlier that the biggest challenge is in these particular patients. They're getting either contemporary state-of-the-art sort of treatment, or more likely they're on some sort of phase 1, 2, or 3 drug, and maybe a combination of drugs. And in the end, you have no idea what's actually happening, whether it's related to the therapy they're getting for their cancer, or whether it's, some traditional cause of pericardial disease that, we might otherwise recognize. And I can't help but remind myself when years ago, and this was when I was at MD Anderson, and they were giving Gleevec for high dose Gleevec for the treatment of CML. And just high doses of Gleevec caused a lot of edema, and there was some association that made initially about heart failure, but actually it was a pericardial effusion that came up at the higher doses of Gleevec. Now, nobody would see that now. I mean, if patients are still getting Gleevec, it's usually at a lower dose, and typically they've moved on to a different drug for their CML, over the last 10 or 15 or 20 years. So, not only do you have to have a broad view about where the patient's coming from, but also all the therapies that they're on, you really have no idea whether that therapy is associated with a pericardial problem. And
Yeah, and
you might be noticing the first case, and so
that's so
that's
true.
the I mean, that's the adds to the whole complexity. And you already mentioned about checkpoint inhibitors. They are
And
great
yeah,
drugs, but they're activating the immune system, and here you are, you want to turn it down.
yeah, it's such a complicated patient population, and it defies everything we know in cardiology, right? When you start practicing cardio-oncology and you're managing STEMI with just aspirin and not being able sometimes to take them to the cath lab, it defies all the logic when you start in the practice. But then you know how to you experience medicine in a different realm, and there's no better topic to discuss how complex management of pericardial disease than this forum that we're having. So when we talk about medications, there's a slew of medications that are implicated with pericardial disease, right? Traditionally, we talk about radiation therapy and the higher doses of radiation therapy and the higher field of irradiation that the patient gets, the more likely they're going to get pericardial effusions, upwards, and sometimes almost half the patients who receive more than 30 grays of radiation, and that's not infrequent in patients with uh, lung cancer or mediastinal masses. Um, they get hefty doses of radiations, and these are, again, very commonly implicated with pericardial effusions, pericarditis, whatnot. But now the new frontier in managing cancer, I mentioned immunotherapy, but also CAR T therapy, which is a form of immunotherapy, very high associations with pericardial effusion. But let's step back. Other agents, which we often see our patients on, such as the anti-metabolites, such as 5-FU, capecitabines, also very high incidence of pericardial disease. Agents on the order of BTKI inhibitors that are commonly implicated as well have a very high, you know, the incidence of pericardial disease in those patients is not as frequent, but they can. And when we look at, these package inserts, and when you look at the adverse reactions, pericardial tamponade, these patients come in occasionally with pericardial tamponade. So, and the list goes on and on. And the combination of the therapies in a location that we practice with phase 1, 2, and 3 trials, we're often the ones that are reporting a lot of these adverse events, which is, I guess, a blessing, but also makes it a lot more challenging for us on a day-to-day basis. But it's something that we're very vigilant with. I'm an imaging cardiologist, but I do bedside pericardiocentesis. Um, and that speaks to the frequency of this disease state that we see. So it's not infrequent that we get called in the middle of the night with a patient in Tampa, first presentation to MD Anderson, and it's one of the non-interventional colleagues on call. So we have to take care of business, and so you get comfortable with these disease states, even as a non-invasive advanced imager, because of the practice realm and how frequent it is, unfortunately.
No, that's really interesting, and I guess coming towards the end of this really fascinating discussion, are there any? I mean, you've already touched upon the IL-1 blockers, but are you aware of any other new treatments or any new approaches that we may be developing for managing pericardial disease in cancer patients? Anything on the horizon we should be looking out for?
I think we're, as far as we need more data, and we need folks publish their experiences, and hopefully we can put our data out there with these IL-1 antagonists. I think it has great utility in our patient populations. In the cases that we've seen, the patients have done really well. And even in our practice setting, getting buy-in from certain departments has been much easier than others. So hopefully we can get a lot more data published that we can start utilizing those agents more often than not, and then over time develop new pathways. I think the inflammatory pathway within cancer patients is just so complex, and it depends on the cancer type, and how they're getting treated may activate different mechanisms within this even more complex realm of therapies. So the more information we have out there, I think will help us develop newer agents as well.
Well, Dr. Khalaf, this has been a fascinating discussion. Thanks for sharing your expertise with us, and we definitely look forward to the publication of some of that data. I think that is a common refrain in the cardio-oncology world. We need more data.
More data it is.
Yeah. Thank you so much for spending the time with us. Dan, Arjun, thanks for being with us today as well.
Thank you.
Great.
Again.
Thank you. Yeah. Thank you so much. This is really interesting. And we look forward to hearing from you again sometime whenever we can work that out.
I hope it will happen sometime soon. Thank you again.
Thanks.
Bye.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.
Free audio post-production by alphonic.com.